So I will start this session. Thank you. So, hi everyone. Welcome to the INICET Radiology Recall Section NEET 2023. So, when I analyzed the difficulty level of the exam from my colleagues as well as from my juniors, I came to know that the exam was a moderate to tough level of difficulty, and the questions from PSM, pharmacology, ophthalmology were of little higher level with higher amount of difficulty. But gladly, the questions from radiology was little more easier. So I hope everyone has done well. So we will discuss the questions one by one. So this was one of the easiest questions they asked. They gave you an image and they asked you to make the diagnosis from the image. And we have done this exercise again and again because this is a very important topic. Okay. So in this image, what we are seeing is we are seeing the fluid filled common bile duct is dilated and there are multiple black or hypointense lesions are seen within the common bile duct. So when you are seeing some lesions within the common bile duct, we all know the diagnosis will be or the answer will be choledocholithiasis. Okay, so what is this investigation? Why this is important is this is MRCP. We all know what is MRCP. MRCP stands for magnetic resonant cholangiopancreatography. And we are seeing the fluid filled structure as bright structures. So in our revision classes as well as in our daily classes, what we have learned is fluid will be bright in T2 weighted images. So this is a heavily T2 weighted image. So MRCP is a heavily T2 weighted imaging technique. So this is an imaging technique that will help you to make the diagnosis of cholelithiasis, choledocholithiasis, periambulatory carcinomas, any stone in MPD and all. And in the exam, in the image which they have given, they are given a dilated common bile duct with multiple calculating. So the diagnosis was choledocholithiasis. So this was we have discussed these things in our revision classes. So if you are seeing two ducts dilated, then you have to understand that there is some carcinoma or some neoplastic process going on in the region of insertion of common bile duct on MPD, resulting in dilatation of both CBD as well as MPD. So that is known as double duct sign. We have discussed all these things. And always remember, MRCP is nothing. This is just an MRI technique which uses heavily T2 weighted images so that fluid is brilliantly seen. Only fluid will be seen, and we will be able to pick up lesions in and around the fluid filled structures. That is the basic phenomenon of MRCP. Okay, so if it is a cholelithiasis, we will be able to see the stone within gallbladder. See here we are able to see multiple stones within the gallbladder, but the common bile duct will be normally seen. And sometimes what happens is when there is an obstructing calculi on the distal end of common bile duct resulting in dilatation of common bile duct, we will get a sign known as the meniscus sign because the stone will not be seen. Only we will be able to see the meniscus. So that is known as the meniscus sign. So when you are preparing for future exams, you should be thorough with the detailings of MRCP. You should know how MRCP depicts gallstones, how cholelithiasis is seen, how choledocholithiasis is seen in MRCP. All these are very, very, very important when you are going for your exams. Okay. So I hope this is clear. I hope everyone has made this correct. So we will move forward. This is another very important question because bone tumors are very, very important. It involves overlapping of orthopedics. It involves overlapping of radiology. So usually examiners will tend to ask all these questions. So bone tumors are very important. So this was a classical case of osteochondrioma. So the history given was a young boy with swelling above knee was presented to you because the swelling was increasing in size. So radiograph was obtained. Which of the following statement is correct regarding the malignant transformation of the lesion? So they were asking which of the following is correct regarding the malignant transformation of the lesion. So that was the question. And the first option is cartilage capillus thickness of more than 2 centimeter on MRI. So that was the first option. Appearance of the pain was second option. Growth towards the joint is the third option. And continuity with the marrow cavity on imaging. That was the fourth option. So these are the four options. So understand that this is osteochondroma. So osteochondroma is nothing. It is exostosis. So what happens is the bone will grow away from the joint cavity in continuation with the marrow cavity. So this is the marrow. So the marrow cavity will be continuous. The bone will be going away from the joint. See, this is the joint. So the bone will be going away from the joint. So all these are the normal characteristics of osteochondroma. The main important thing with osteochondroma is you have to understand that it is prone for malignant transformation. They can undergo malignant transformation. Not always, but they can undergo malignant transformation. And the most important indicator to identify malignant transformation is the presence of cartilage cap thickness more than 2 centimeters. Some literature says more than 1.5 centimeters. Anyway, more than 2 centimeters is absolutely correct. And cartilage cap will be visualized only in MRI. Cartilage cap can be seen only in MRI. In X-ray, we will not be able to see any cartilage cap. Okay. So that is the concept. Okay. Always understand that in X-ray, we will, because usually if you take an MRI like this, there may be a cartilage cap like this. And if the cartilage cap thickness is more than 2 centimeters, then it denotes malignant transformation. Okay, so that is the take-home point. So I think this will be the correct answer if these are the options provided. So we will move forward. Yeah, already we have discussed all the bone tumors in our previous revision sessions, and always remember this point: cartilage cap thickness of more than 2 centimeters is always indicative of malignant transformation. Always understand that that can be picked up only by MRI. MRI will help you to pick up the cartilage cap thickness. Okay, so that is the point. Another very important topic is mammogram. You know, mammogram, breast cancer, all these are very hot topics for the exam. So you need to have very good understanding for mammogram. And this question was a little bit easy because it was asked, they were asking you which of the following is not an advantage of ultrasound over mammogram. So just understand that for imaging of the breast tissue, you have to understand for imaging of the breast, the two very important modalities are USG breast and mammogram. Okay, both of them are having their own advantage as well as disadvantage. So the first option was ultrasound can be used to detect palpable tumors that are undetectable in mammogram. That was the first option. We will wait. Second option is it can be used to differentiate between solid and cystic lesion. So the examiner is telling you ultrasound will help you to differentiate between solid and cystic lesion. So that is the second point. Third option is it can be used for guided biopsies. When you work in surgery as a house surgeon or a JR, you will know you will send patients to ultrasound for doing USG guided FNACs or biopsies for lesions that are not palpable or that are very less in size. Okay, very less than 1 centimeter or 2 centimeter in size. For getting the accurate sample, we know we will send the patient for ultrasound guided biopsy. So that is absolutely correct. And ultrasound is having a better side when we take ultrasound for a patient with a dense breast. So all the 3 points are absolutely correct because the sensitivity of the mammogram is inversely proportional to the density of the breast. Okay, sensitivity of mammogram is inversely proportional to the breast density. So in young age, the females will be having a dense glandular breast tissue. What happens when the patient gets old or the female gets old is the dense glandular tissue will get replaced by fat. So in older people, it will be the mammogram will be having better sensitivity. But in a young population, what happens is because of the dense breast, the imaging with the mammogram will be suboptimal. We will not be able to find out lesions in breast when the fibroglandular parenchyma is very dense. So that is the concept. Okay. So all these points are correct. And I think this is the wrong option because whenever the lesion is palpable, it will be usually detected by mammogram. So I don't think the palpable lesions will be missed in mammogram. I'm not sure whether this is the exact option. These are the options which these options I got from my friends who wrote the exam. Okay. So I'm not sure whether this is the accurate option. I'm not sure, but all the 3 statements are correct. So you have to understand that ultrasound is excellent in breast imaging. It helps you to differentiate whether the lesion is a cystic lesion or a solid lesion. You will be able to put a needle under the guidance of ultrasound. You can take biopsies or FNACs, whatever as per the requirement of the treating surgeon. And also ultrasound is an excellent screening modality when you deal a young female with a dense fibroglandular breast. Okay. So all these 3 points are very, very important. Just keep these points in your mind. Now, this is another excellent question. And why it is very important is because blunt trauma to the chest, rib fractures are routinely encountered in our day-to-day practice. Daily, when you are in your emergency room, definitely at least 1 or 2 patients will come to you with a blunt trauma to the chest. So you should know how to look for a rib fracture. How will you see a rib fracture like that? And always understand that how to count. The how to count ribs are very important. Okay, how to count the ribs. This is the very important point from this question. I don't know what image came in exam, so I just took a random image. I will show you how to count the ribs. Okay. Anyway, they can simply put the options like 2, 3, 4, 3, 4, 5, 5, 6, 7, and they can confuse you. So you should know. You should know how to count the ribs properly. We know the. So see, this is the first rib. You have to trace the rib. The posterior aspect of the rib will come near the vertebral bodies at the costovertebral junction. So this is the first, and behind that this is the second, this is the third, this is the fourth, this is the fifth, this is the sixth, this is the seventh. So this is how you should count it. You should give a little bit attention. You have to see where the first rib is going to attach. That is the first rib. Below that is the second rib, then third. So you should never make this practically applicable questions wrong, because these are very, very important for your day-to-day life. Whether you are a surgery resident or an orthopedic resident or a medicine resident, what happens is the patient will come to you, they will take an X-ray, they will give you. So you should know how to find out a fracture, how to count the ribs, and how to put ICD. All these things are very important. So this is a very important question. So if you see, here you can see there is a break in the continuity of the cortices. So these are the fractures. So here in this image I have put the rib fracture are 6 to 7. Commonly encountered rib fractures are 5, 6, 7. We all know these things. Okay. So this is how you should properly count the ribs. So you have to know the fundamental. Only if you know the fundamental basic, then you can count the ribs and you can make the question correct. In future also, they will ask these type of practically applicable questions. So you have to be very, very thorough in finding out how to count the ribs. Okay, I hope this is clear. So we will move forward. This is another question. This is not purely radiological. This is a mixture of anatomy, radiology, surgery, everything. So the examiner is asking you to match the following with regard to thyroid swelling causing obstruction. So if the thyroid swelling causes obstruction to the trachea, what happens is the patient will present with a dyspnea. You know, it will push and compresses the air column. The patient will be having dyspnea. So that is easy. If it compresses esophagus, then the patient will be having dysphagia. This is a very easy question. Okay. If it compresses rectal laryngeal nerve, the patient will be having hoarseness of voice. And if it compresses sympathetic chain, the patient will be having Horner syndrome. So all these are the things that we have studied in various subjects like medicine, anatomy, physiology, and all. So you have to just compile all this and make this question correct. So this is another easy question. So this is another very, very easy question they asked from an anatomical variant. So they asked you to find out an anatomical variant. They have given an image like this, and you are able to see a incomplete septa like this. And you know this is not a polyp, this is not polylithiasis, this is not a floating gallbladder. This is within the liver only. It is not going anywhere, so it is not a floating gallbladder. So this is the Phrygian cap. Okay, so this is a Phrygian cap. Here you are seeing the cap-like structure. Okay, so this is a Phrygian cap. So you know how to find a polylithiasis, right? In gallbladder, you will be able to see a calculi like this. And what happens in cholecystitis is there will be thickening of the wall of the gallbladder. So this is how you identify polylithiasis, choledocholithiasis, and cholecystitis. Okay. What happens in cholecystitis is there will be thickening of the wall of the gallbladder. The wall of the gallbladder will be more than 4 mm. Okay. GB wall will be more than 4 mm in thickness. So that is the finding in cholecystitis. So ultrasound of gallbladder is very, very important because it is of high practical importance. That is why they are repeatedly asking questions from gallbladder and ultrasound related to gallbladder. Another very much straightforward question, a question that we don't expect in INICET type of exams, is regarding this direct question of banana sign. Banana sign is seen. You know this banana sign and lemon sign. Both these signs are seen in spina bifida. Okay. So this is the banana. The posterior fossa looks like a banana. So this is the banana sign. Okay. So you should be thorough with banana sign, lemon sign. Okay. This is another easy question. This was a case of a young boy with a fever and abdominal pain, and there was a history of blood in stool for last 7 days. So the patient is having fever, loose stools, blood in stool for past 7 days. And when you do an ultrasound, you are seeing a hypoechoic lesion with irregular borders in posterior superior aspect of the right lobe of liver. So when you are doing an ultrasound, you are seeing there is an irregular hypoechoic lesion in right posterior superior aspect of right lobe of liver. Okay, so what is the diagnosis? Whether this is an amoebic abscess, a pyogenic abscess, or highlighted cyst. So you know from the history itself, it is very easy because the patient is having bloody diarrhea. That means the patient is having colitis plus liver abscess. So it is automatically related. Amoebic abscess will be presenting with the colitis because the infection starts from the intestine. Okay, so you can solve it like that, or usually amoebic abscess will be single in number. It will be seen in posterior superior aspect of right lobe of liver. All these are predicting factors for amoebic abscess. So you see, this is how a liver abscess is seen in ultrasound. This is an ultrasound image showing an irregular hypoechoic lesion in right lobe of liver. So this is how a liver abscess is seen in ultrasound. And if you take the CT, you know this is the kidney. So this is the right side, the right kidney. So this is the right side. So this is segment 6 of right lobe of liver. So there's a single well-defined abscess. So this is amoebic abscess. And what happens in pyogenic abscess is you will be seeing multi-septated abscess, multi-loculated abscess. And what is the sign known as? That is the cluster sign. There will be clustering of the abscess. Okay, that is known as cluster sign. So all these are features of pyogenic abscess. So in our question, the patient had abdominal pain, loose stools, bloody stools, single loculated, single irregular abscess in right posterior superior lobe of aspect of liver. All these were directing towards the amoebic liver abscess. I hope that is clear. And you should know, in CT, there one sign is known as double target sign will be seen in liver abscesses, as well as because of the multiplicity. What happens is the liver abscess, the pyogenic liver abscess will be shown in cluster sign. Cluster sign is a feature of pyogenic hepatic abscess. All these things we have already discussed in our previous classes. If you know the concept, then you can easily make these things correct. Okay. Then another interesting question they asked was about thymoma. They asked us to correct the find out the correct statement regarding thymoma. The first option provided were X-ray is the investigation of choice. Second was it can cause dysphagia. That is partially correct. The most common location of thymoma is in the posterior mediastinum. Fourth option was most common neoplasm of thymus. So you have to understand that thymoma is the most common neoplasm of the thymic gland. So that is the correct statement. X-ray is not the investigation of the choice. X-ray can be the first investigation because when you take an X-ray incidentally, you may see the widening of the mediastinum, or there will be some mass lesions in the region of heart or mediastinum. So, but if you want to characterize the lesion, then CCT chest, CCT thorax is the investigation of choice for anterior mediastinal mass. If they are asking about posterior mediastinal mass, then this neurogenic cyst or neuroglial cyst, all these posterior mediastinal masses, then MRI will be the investigation of choice because MRI will help you to find out the continuity with the neural canal. That is why for posterior mediastinal masses, MRI is the investigation of choice, whereas for anterior mediastinal masses, CCT thorax is the investigation of choice. So the thymoma is most commonly seen in anterior mediastinum. And if you ask me the name of posterior mediastinal masses, then you have to understand that any neurogenic tumors like schwannoma. Okay, all these are the posterior neuroglial cysts. All these are posterior mediastinal mass, and for posterior mediastinal masses, MRI is a better investigation than CCT chest. Okay, so keep all these things in mind because they have asked about anterior mediastinal mass in this exam, so they can ask you about posterior mediastinal mass in the next exam. Okay, just keep it all these things in mind. I think this is the last question. Okay, so this was in history. There was a middle-aged patient with a history of back pain, fatigue, dysuria. X-ray abdomen was given. Some were saying the X-ray was showing multiple calcifications, mostly renal characteristics. Some were saying it was since it was bilateral symmetrical, it was medullary nephrocalcinosis. So whether it is medullary nephrocalcinosis or renal calculi, both can come in cases of parathyroid hyperparathyroidism. Okay, both medullary nephrocalcinosis as well as renal calculi both can come in hyperparathyroidism. So the most common cause of primary hyperparathyroidism is parathyroid adenoma. So here the patient was having bone pain, dysuria, fatigue, and all these things. So it was a direct question. Okay, so it was not a case of ankylosing spondylitis, nowhere related to cystic fibrosis. So when you are finding bone pain, renal stones, or medullary nephrocalcinosis, all these things you have to understand that this is a case of primary hyperparathyroidism, most probably because of a hormone secreting parathyroid adenoma. I hope that is clear. So this also we have already discussed. So when you see a putty kidney, there will be involvement of both renal, medulla, and cortex. Whereas Staghorn calculus, like appearance, the Staghorn calculus will only involve the renal pelvic region. The renal shadows will be spared. Whereas medullary nephrocalcinosis, what happens is there will be calcification along the medullary pyramids. Okay. So somewhere telling me that it was an image of medullary nephrocalcinosis. Somewhere telling it was renal calculi. So whatever it is, both can come in case of hyperparathyroidism. The patient will be having abdominal pain, groin pain, mons, then back pain. All the bony pains will be there. So that was a case of primary hyperparathyroidism because of parathyroid adenoma. So I hope the questions from radiology were little more easy compared with the questions from other subjects. So for when you prepare for your next NEET exam or INICET November sessions, you have to be thorough with all these topics. Mammogram is very, very important. Mediastinal masses will be important. Hyperparathyroidism is one of the favorite exam topic for these AIMS examiners. So all these topics are very, very important. But when we compare this exam with the previous year INICET exams, the previous year topics that got repeated were less compared with the last time. This time they trying to find out something new, I guess. But still, all the best. Yes, I hope you have done really well. So we will eagerly wait for your results. So thank you.